Hi, everybody. I think from my presentation, I'm going to start off by giving a couple definitions. And just to say that as a way of introduction, I'm going to focus on severe acute malnutrition or wasting. And I think Patrick will complement that specifically with more emphasis on some of the products that we use to treat. So I'm just going to talk about some of the challenges for treating these forms of malnutrition. So if we just talk, and Dan already mentioned it in some of in the first panel, but just in terms of being clear on terminology, we are talking about undernutrition and specifically acute malnutrition with two forms that are really common, both marasmus and kwashiorkor. And really, these forms occur quickly and as a result of rapid weight loss. We'll also touch a little bit on chronic malnutrition, but just keep in mind that that's often referred to as stunting, and that occurs as a result of inadequate nutrition over time. And in some of these contexts where we're talking about protracted long-term crises, we're also seeing the overlap between children who have both forms of malnutrition and sometimes multiple incidents of wasting when they're already chronically malnourished, which is problematic. In terms of the cutoffs that we use sort of from an emergency nutrition standpoint, these are from the World Health Organization. And there are two categories that I'll talk about in terms of addressing the issue of malnutrition. So severe acute malnutrition is defined as this less than -3 standard deviations from a normal prescriptive growth curve, and then moderate acute malnutrition is greater than that, -3 Z-scores or standard deviations. And so you'll often see, in reference to defining famine and in the IPC scales that were discussed in the first panel a little bit, we're looking at this total global acute malnutrition, or GAM, and that's really just taking the severe and the moderate and adding them together. And I think one of the things that I'll talk about is just the use of MUAC, or mid-upper arm circumference, and how that's really simplified both the definition of malnutrition and also being able to define famine in some cases more easily. So in terms of the history of where we are now in terms of addressing acute malnutrition, when I think I started off working, or some of you probably recall, there was a real inpatient focus. So most children were treated in a clinical setting, and so it was very difficult for a number of reasons to be able to have a clear understanding of how many children were actually in need of treatment, but also it was difficult to reach a large number of children because of the opportunity costs involved. Excuse me. So in that hospital approach, some of the main challenges included big cross-infection. So somebody mentioned earlier in terms of disease. So there was a lot of cross-contamination, and so there was a much higher rate of death, mortality, even in treatment. And then there was also a huge issue of just overcrowding because of the numbers of children. There were also very high rates of defaulting. So because that inpatient treatment often took a month, or in some cases 6 weeks, often children and their families wouldn't be able to stay. Also, since we're seeing a lot of targeting of aid workers, and particularly health facilities, the issue of whether or not people were safe staying in an inpatient facility for a month or 6 weeks was another problem. And so 3 main things changed kind of 18 years ago, or in 1999, 2000. And those 3 changes allowed for the inpatient treatment to be moved more into the home and into the communities. And these 3 things included the adoption of MUAC, or the mid-upper arm circumference, as an independent criteria for defining children, particularly children between 6 and 59 months, as malnourished. And also this categorization of severe acute malnutrition. In the past, before kind of 2000, there was this assumption that all severe acute malnutrition needed the medical treatment in the hospital. But with this delineation of saying that some children did not have medical complications, there was the possibility, particularly with WHO, to be able to treat those children at home. And then the final piece that I won't talk too much about is the development of ready-to-use therapeutic food, which many of you have heard about in the context of famine response. It's one of the commercial names is Plumpy Nut, but there are something like 19 producers of RUTF worldwide. And I think what's happened now is that we have, in many of the famine-prone countries, there are probably about 3 million children in some of the countries that we're talking about today who are in need of treatment. And despite these advances in bringing the treatment to a community and to a household level, there's still been difficulties in really achieving any kind of coverage. So programmatic coverage for really reaching children has hovered anywhere between 30 and 60%. And so in humanitarian contexts. And so because of that, there's been attempts to try to modify the way that children are reached in an effort to try to improve quality, but also increase coverage. And some of the modifications that I think are just interesting in the context of trying to identify pockets of famine in particular are trying to combine a treatment protocol, so trying to treat children earlier on this continuum of malnutrition, playing around a little bit with dosing, so not needing as much RUTF, for example, at the end of treatment, maybe giving children more at the beginning. There's been a pretty widely accepted use now of not needing always having community health workers kind of go door to door to screen children. So with that MUAC as the tool to identify children as malnourished, what has kind of been realized, which seems like common sense, is that actually mothers and fathers, if you give each family a MUAC tape, they're able to screen their own children on a regular basis, which is particularly useful in insecure settings where people might not be able to access households. And so that, in the past probably 2 years, is something that has really been adopted. So it's being rolled out in Somalia, in most countries in West Africa, not in Ethiopia, but in Yemen. And so that really is one of the modifications to the existing protocol that's trying to address this issue of access. And then the last modification is just the integrated community case management, or trying to actually empower community leaders and community health workers to be able to treat children directly. And so again, trying to overcome some of the challenges in terms of access, in terms of budget, in terms of supply pipelines, and also in terms of medical staff and capacity. Just the lack of sort of nurses and doctors who are actually available to work even in the outpatient feeding centers, doing this approach, having community health workers empowered and trained to actually treat malnutrition is another way to try to overcome some of the access issues. And then finally, just this recognition of, and this is something that's particularly challenging to talk about in terms of getting consensus, but there's a general agreement in the emergency nutrition community that there's no reason to wait until children get to this point of severely, acutely malnourished. And it does fit into the tools that we have to define famine, but in fact, once children get to that point, they already have up to a 9 times greater risk of death and mortality than a normally nourished child. And so there has been this push to try to intervene earlier, particularly in places where we do have maybe not early warning data, but we have some indication based on historic trends that there are more and more children who are in need of treatment, particularly during peak times. So the idea is to try to treat children who aren't actually yet malnourished in a way to try to prevent them from becoming malnourished. And speaking to that also is this issue of disease burden and trying to really have a better package that addresses underlying infection or prevents underlying infection. And I think the challenge with this is that if we redefine in this nutrition community the way of defining malnutrition or trying to prevent children from even becoming malnourished, it changes and shifts a little bit the data points that we're using in defining places that are suffering from famine. And so that's one piece that we haven't figured out. But it's also difficult with the UN agencies to get consensus around, are we actually preventing or should we just be in the business of treatment? The big ongoing research now, there's been this gap with the moderately malnourished children for my entire career in terms of no global guidance nor consensus around how to actually treat these children. And so that's where this question of the continuum and the idea to try to prevent malnutrition earlier comes in. And I would just say that all of these programs are based on data. I mentioned trend analysis, but there are also standard nutrition surveys that are done in many of the countries that are on whatever famine watch list. And so those surveys, sometimes it's NGO partners, sometimes it's Ministry of Health staff who actually are going and doing household level surveys that are anthropometric measurements, but there's also just a lot of data from those surveys around morbidity and also mortality. And so that's what also feeds into the IPC process. And then the other piece is from these programs that I'm talking about, there's routine monitoring data for each child. And so those are also data that are available for us to make some type of decisions in terms of humanitarian response about whether the situation is getting better or worse. Whether or not those data are available on a timely basis is always a challenge with a lot of data and humanitarian response. But I would say that in many of the contexts where we're talking about very high levels of acute malnutrition, those trend data do exist, but we often lose them at a very center level, so they're aggregated up, and so it's difficult to be able to see the kind of center-based trends. It's just you get a more regional, monthly picture. And I think that's something that many partners, UNICEF and WFP together, and WHO have been trying to figure out different systems to do a better job of capturing that data in real time. So there have been some initiatives, but none of them have caught on to be kind of the gold standard one that everyone has adopted. Another piece, Dan mentioned a little bit, but I think a big shift in responding to acute malnutrition, since, I guess, even before the response in Haiti after the earthquake, but in response to the earthquake, this was really the focus, looking at infant and young child feeding. And there has been, just because of all the research that Patrick and others have been involved with, even in non-humanitarian settings, that recognition of the importance of young children and the vulnerability of children between 6 and 23 months in particular. There's more and more emphasis in emergencies in trying to figure out how to address infant and young child feeding needs. And so the two main areas are breastfeeding support, lactation support, and controlling breast milk substitute donations, which in contexts like Syria and the Ukraine have been impossible or not possible to control, but trying to find a way to best meet the needs of mother-baby dyads. But I think this area has really changed a bit the view, particularly in urban settings where women in particular were maybe not breastfeeding pre-crisis. And so there's been some really interesting work on that. And just the recognition of how this infant and young child feeding programming is an entry point for a lot of psychosocial support, particularly for crisis-affected populations. So in the context of Syria now, we see that actually many women are breastfeeding, but they're just not doing it more than once or twice a day because of psychological trauma and depression. And so it's not really a situation where the normal tools that we have are actually applicable. So these challenges in terms of redefining the needs related to nutrition continue to evolve. The other piece I think that's changed a lot in terms of trying to get around with these humanitarian challenges is just, and I think it comes full circle, but just this emphasis on integrated programming. So really focusing, at least for nutrition, on the health and WASH piece. And I think it's limited in terms of the lens through which people have defined what actually works, which piece of the health response and which piece of the sanitation and hygiene response, will actually have an impact on nutritional status. But that said, at a minimum, inside nutrition programs now, inside selective feeding centers, the provision of safe water, making sure that hygiene and sanitation is addressed if at all possible, and then addressing the full preventable diseases, that's a minimum now that's been adopted in places like Yemen where you have an integrated famine strategy. One thing that's emerging on that is just in terms of working with animal health workers, so community animal health workers, for example, and having that as a network to also define and message around acute malnutrition, and also work to look at complementary feeding and increased milk consumption if there is availability. So there are many opportunities for integrating, but the question in terms of research, of figuring out which pieces from all of that, remain. But I do think there, at least within the UN agencies and within the humanitarian donors, there's a strong recognition that without addressing the health, that disease burden, particularly in recent outbreaks with cholera, you see how many children are severely malnourished and have cholera, and the mortality risk is greatly increased. So you have to figure out a way to treat both of those, both the cholera and the severe acute malnutrition at the same time. So I think there's been some progress in that area, but what has not progressed is really the preventing malnutrition, and how do you use resources in the best way to integrate programming to not have the level of malnutrition rise beforehand. The last piece, just to talk through, and I think Jan will speak to it more widely in terms of food insecurity, but just talking through cash transfers to improve nutritional status. I don't have anything very interesting to share except to say that there really is a lack of evidence that actually giving cash transfers in lieu of treatment, if you're actually trying to improve nutritional status, the research that has been conducted has not shown a strong impact on just doing cash transfers and having that wasting reduced, for example. However, the evidence that there's still some, there's still research ongoing, and some of those studies have shown that cash transfers can improve dietary diversity, and also adding cash to treatment of acute malnutrition, for example, can have the knockoff effect of having better and more sustained outcomes. So maybe it doesn't actually treat acute malnutrition, but having a cash transfer in addition to other types of programming, maybe children are less likely to relapse, for example, to become malnourished again. Just to mention some of the challenges with this that I haven't mentioned already, but some of the challenges specific to addressing nutritional needs in emergencies, this reliance on community health workers. So every context that I think I cover where there is some type of emergency nutrition response is very much dependent on a network of community health workers. In the context of Syria, for example, it was very difficult because there was not this network, pre-war of community health workers, so people going door to door and giving messages in some contexts, particularly in urban settings, is not necessarily the norm. So trying to adapt this kind of house-to-house model for the newer context is something that we continue to struggle with. And then the other thing is just the burden on community health workers. So not only are those health workers responsible for nutrition, but they're supposed to be doing hygiene, promotion, and some type of psychosocial reproductive health support. And so all of that we've seen in places like Pakistan, et cetera, can result in a breakdown in terms of that network, and also maybe just a lower quality of programming. I mentioned already the targeting of health facilities, and that has, particularly in Iraq, of course, Yemen, indirectly, and then directly in Syria, there have been all these health centers that have been targeted, which also decreases confidence in the population to actually bring their children who are sick or malnourished to seek treatment. And so that is an ongoing challenge. And I mentioned cholera, but other outbreaks as well. Even in the Ebola crisis, we saw the challenges of actually emerging malnutrition and food insecurity because of people not being able to access markets and because of stigma, et cetera. And then finally, I think we struggle in moving in the emergency nutrition community where there are some people who really are focused on the health, wash, and nutrition piece and feel that children, even in a food insecure population, children can in some settings be protected, and that link between food insecurity and malnutrition is not a direct correlation. But we certainly see in places like Venezuela right now where people just can't access food because of an economic crisis and political crisis. And so there still are these contexts where, doing this type of treatment for malnutrition really does nothing if children just go back into a food insecure household. And so just to try to balance that in terms of budgets, because you will see in a lot of the humanitarian appeals, the biggest line item is still around food security, but how that is layered with nutrition programming and health and wash continues to be a big challenge for emergency nutrition. That's all for me.